Hello, everyone. I'm Eleanor Lee and Spencer. We are from the University of Tennessee in Health Science Center, College of Medicine. And today we are presenting this trial to you that looked at two different treatments for advanced primary hepatocellular carcinoma.
All right. So to get us started, I'm going to kind of just go through some background of hepatocellular carcinoma and just go into some of the details regarding treatment and prognosis and things like that. So to kick us off, HCC is a pretty prevalent disease worldwide. It's the fifth most common type of cancer, and some sources say that it is as high as the third cause of cancer mortality worldwide. So this is a pretty big problem for a lot of people around the world. Specifically, the prevalence is highest in Asia, but the prevalence in the United States and Europe is increasing in the past few years. In Asia, the most common etiology is hepatitis B infection. And then in the West, particularly the United States, Europe, hepatitis C is a leading cause of HCC. But any form of cirrhosis can lead to hepatocellular carcinoma. So as mentioned, Dr. V mentioned in the chat just now, we can see that NASH and alcoholic-related cirrhosis are increasingly seen as some of the more common causes nowadays compared to the hepatitis B and C etiologies due to some vaccination efforts and some advances in pharmacology with the antivirals. In terms of diagnosis, you can go back to that slide, Eleanor, for me. Thanks. In terms of diagnosis, we can use imaging in patients who demonstrate clinical signs of cirrhosis. The first kind of go-to is ultrasound. And then in advanced disease, we can also use CT and MRI. And there are some pretty specific imaging findings on multiphasic CT and MRI that can be used for diagnostic measures as well. All right, you can go to the next one. All right, so in terms of staging and prognosis of HCC, there are three kind of main categories that need to be addressed in terms of moving forward in staging and prognosis. The first is looking at the patient's liver function. And there are a couple major grading scales and algorithms used for this. The three big ones that you can see here are the Child-Pugh grading scale, the albumin and bilirubin grading, and MELD. So Child-Pugh looks at a whole bunch of different factors, particularly bilirubin, albumin, prothrombin time, the presence of ascites and encephalopathy. And those are kind of put together in a point system, and you get a class, which is broken down into class A, B, and C. Albumin and bilirubin grading just looks at albumin and bilirubin, and this is thought to be a more objective view of liver function. Some critics of Child-Pugh say that it's a little bit too subjective since you are taking some clinical data into consideration rather than just hard laboratory evidence. And then MELD is a criteria for liver transplant that is used to often assess liver function as well. The next category that we need to look at is the tumor. So a lot of times imaging is used to assess tumor or biopsy to assess the grading of that. But then, as you can see here listed, there's a lot of different algorithms and guidelines specifically talking about the tumor grading and things like that. One of the most common is this Barcelona Clinic of Liver Cancer algorithm, but the National Comprehensive Cancer Network guideline is another big one. And the European Society for Medical Oncology has come up with their own criteria, which was adopted in Asia, specifically looking at some causes and treatment outcomes targeted at the ethnic groups in Asia. And I bring this one up because it is used in this paper that we are looking at today. So these algorithms kind of help guide prognosis, but they often use the two other liver and patient characteristics to kind of guide treatment. And that brings me to the last point of looking at the patient as a whole. We're always taught to treat the patient in front of us. So there are their own guidelines to look at how well a patient may respond to various types of therapies and things like that. So in this paper, they were talking about the ECOG PS, which is basically a grading scale to determine how much functioning a patient has in terms of they're functioning completely on their own to they are deceased. So there's a scale in that range that looks at how much function they have, and then looking at the patient's cardiopulmonary and renal function, kind of getting a broader sense of how the patient is doing as a whole. All right, and this slide is pretty busy, but this is a screenshot from the Barcelona Clinic algorithm. So you can see here on the left that it kind of takes into account a lot of different things that I just mentioned in terms of the ALBI score, Child-Pugh, and MELD up there in the top left, all the way working down to kind of the clinical decision-making to look at what treatments we're going to do in the prognosis with the expected survival. But in terms of treatment, there are kind of 5 broad categories that are used today for treatment of HCC. And the 5 main categories are surgery, ablation, the intra-arterial treatments, the radiotherapies, and the systemic treatments. So surgery can be further divided up into resection and transplant, as you can see here on the flow chart. And this is one of the preferred methods of treatment because it is considered a potentially curative therapy. But there are some caveats. You have to determine whether the patient is a good candidate for surgery. And if they are a good candidate for surgery, are you going to do resection or transplant? If you're doing resection, you have to be careful about the patient's liver function, and you don't want to be in a place where you are putting them into liver failure by resecting too much. And those kind of have their own guidelines for which patients receive which. One thing that is of note is the criteria for, they say like 1 under 5 or 3 under 3. You can see here in kind of the middle of the screen on imaging, a lot of times patients may have multiple nodules. So you're looking at the size of the nodules in conjunction with the number of nodules. So 3 nodules less than 3 centimeters or 1 nodule less than 5 centimeters. This can typically lead you down the road towards transplant if all of the other criteria are met for that as well. In terms of intra-arterial therapies, this is a lot of where IR comes into play, which we'll talk about in a little bit with TACE and various treatment modalities like that. Radiotherapy is typically extra-arterial approach using like stereotactic body radiotherapy and things like that. And then the systemic therapy with the tyrosine kinase inhibitors and all the other various chemotherapies that you see listed on the screen there. And yeah, I think you can go to the next slide. We can't hear that, Eleanor.
Chemoembolization. It is a minimally invasive, image-guided treatment for cancerous liver tumors that combines embolization and chemotherapy.
During TACE, an interventional radiologist uses fluoroscopy to guide a thin, flexible tube called a catheter into a pinhole at the hip or wrist and through the blood vessels to the liver. We use the catheter to inject tiny beads coated with chemotherapy into the blood vessels that lead to the cancer. The beads deliver a high dose of chemotherapy directly to the cancer with minimal effect on nearby healthy tissue.
The beads are designed to shrink the tumors by blocking the blood supply that feeds them. This process is called embolization. It also concentrates the chemotherapy around the tumors.
All right, so I thought that was just a nice little video, kind of having some graphic representation as well as some explanation of what TACE is. That is kind of a project that was making these videos designed towards patients that were undergoing these procedures. But as the video describes, TACE is a procedure that combines traditional trans-arterial embolization with delivery of local chemotherapy to kind of have a synergistic effect on blocking the blood flow to the tumor, as well as delivering cytotoxic chemo in a local fashion. And as I mentioned earlier, these treatments are generally used as standard of care for unresectable or large HCC burdens in patients that may not be able to undergo surgical resection or transplant or anything like that. And in terms of, there are multiple categories within TACE as well. So there's kind of conventional TACE or drug-eluting bead TACE, and that just kind of is describing the exact mechanism for how you're delivering the radial embolization. And there's conflicting data that I found whether or not one is superior than the other. There are some theoretical benefits of the drug-eluting bead ones, but a lot of these were not specifically studied for hepatocellular carcinoma from what I found. But it is nice to know that there are two different types, and we can have some further discussion on that after Eleanor gets through her piece as well. All right, and wrapping things up here, just kind of looking at treatment response. The paper goes into a lot of this because it is very important to determine if the treatment that you're giving the patient is actually working. So the RECIST and mRECIST criteria is using imaging to kind of determine whether or not the treatment is successful or not. Specifically, mRECIST was developed for HCC to look at whether or not there was either complete response, partial response, progressive disease, or stable disease regarding the HCC treatment. So the typical kind of flow, as you can see from here on the bottom, you have baseline imaging, and then you undergo the treatment of choice, then the follow-up, and then the radiologist will determine whether or not it's CR, PR, SD, or PD. And so one of the things that kind of came about for the development of mRECIST was that some of the treatments for HCC on imaging will cause the lesions to grow due to kind of the mechanisms of action for these treatments. So if you typically look at a lesion that's growing, you may think that the disease is progressing, but in reality, the treatment is actually, it's responding, the tumor is responding to the treatment. It's just the mechanism of the treatment is causing the imaging to respond in that way. So mRECIST was developed specifically to combat that kind of issue with the classical RECIST. I believe it's RECIST 1.1. And the paper uses this to evaluate treatment response. All right, and last but not least, kind of determining why is this important? Why are we talking about HCC? As I mentioned, it's a very common type of cancer, and the mortality is fairly high worldwide. And like I mentioned, with all of the various algorithms and treatment plans, there's not necessarily a good consensus on staging and treatment. There's a ton of different options. in terms of surgery, a lot of the surgeries depend on surgeon expertise or whether or not the radiologist reads the dimensions in a certain way. So there's a lot of variables going into staging and treatment. And patients don't read the textbook, right? We have all these treatment algorithms, but oftentimes a patient that walks in into the door of the hospital isn't going to fit neatly in one of these boxes that we have on the treatment algorithm. So looking at various options of treatment, combining one or the other may have a benefit, as we will discuss later. And then there's not a great consensus on screening, predictive biomarkers, or prognostic metrics, just kind of further emphasizing the fact that HCC is still being fully understood and the treatment options are still being fully understood and studied. So this is a good field of research, and this paper is pretty exciting, looking at the implications.
All right, so a quick introduction to the paper. What are we studying? We are comparing the effect of lenvatinib, which is a systemic chemotherapy drug, combining with TACE, and compare that with lenvatinib alone, which we will refer to as monotherapy from now on. And the premise is that the researchers' hypothesis is this combination of treatment will have synergistic effect and thus produce a better outcome, measuring median overall survival and progression-free survival for the patient in that group. The endpoint is determination endpoint is if there's a progression or unacceptable toxicity, then we will categorize that as the end for the patient in the study. Okay. So lenvatinib is a NIB, so it's a kinase inhibitor. It's a multi-kinase inhibitor. It's really its potency is comparable to sorafenib in the amount and the types of growth factor target that it can target. And as you can see here, it can go through a lot of pathway and block those replication of tumor cells. The methods in this study include that the patient will have to have an advanced primary HCC diagnosis between this age, and we want to make sure that they have expected to live long enough to experience the benefits of each each treatment. So life expectancy of more than 3 months. They will also need to be relatively stable at the current state to undergo these treatments. And the major exclusion criteria is a history of hepatic decompensation, which puts them at a worse baseline compared to other patients, as well as central CSF metastasis, which really marks poor prognosis that wouldn't match with the life expectancy inclusion criteria we talked about earlier. And of course, if they're contraindicated for TACE, then they cannot be participating in this study. Okay, before we dive into methodology, I want to spend a little time to talk about the design of study. And for those of you out there who may want to run a trial in the future or just want to appreciate the stats in this paper more, first of all, randomized versus non-randomized is pretty straightforward. If you are randomized, that means that upon enrolling into the study, the computer decide which treatment arm you're going into, versus non-randomized, where the researchers designate your treatment arm. Open label means that the researcher, interventionist, and the patient all know what treatment you're getting. Obviously, double blind is better, but we are justifying this case of choosing open label because for 2 reasons. One is that TACE has unique toxicity associated with it, and the researchers would like to know or keep an eye on patients who had TACE. Also, second one, which is more major, is that if you want to do double blind this study, you will have to devise a new protocol for sham surgeries for patients who are in the monotherapy group. And that might not be really realistic in terms of resource-wise for the study. Next, parallel versus crossover. Parallel means that once the patient is designated in the beginning of what treatment group they're in, they're staying in that group. They cannot at any time point go cross over to the other arm. And crossover is the opposite of that, where there are designated time points where patients can go to the other arm. Crossover works best when you are expecting to enroll less patients. because for various reasons, maybe it's a really new drugs or whatnot. And the patient in this case serve as their own control, because in the beginning, usually it's the placebo phase where they're not receiving anything. That's like their baseline you're establishing. And then they then cross over to the treatment arm and you're comparing what happened afterwards. Obviously, parallel is still better. It provides a more rigorous, it would provide more rigorous results and evidence. Intention to treat versus per protocol is getting a little bit into the weeds of study design. Per protocol means that, well, we've all read studies, and what's one thing that every trial have in common? It is that there are bound to be some patients who fell out or follow up or are non-compliant in terms of they didn't receive all the entirety of the treatment. So then what do we want to do with that? Per protocol is a study design or analysis design that will exclude those patients. So if they are lost to follow up, if they didn't receive the entirety of treatment, then we're going to exclude them from our analysis. And that creates bias because that's not how it works in real life. So recent studies gravitates towards using intention to treat design, where we're including all patients at the end of analysis. And it's criticized by, some people criticize this method by saying that you're not looking at the potency of the drug then, because you're diluting the results, including people who didn't receive fully of it. However, we almost kind of prefer that, because a lot of these trials are comparing our superiority or non-inferiority trial, where you already have an established regimen and you really want to see if this new thing is a lot better compared to your established regimen. So if they can pass this test of this conservative almost test of still showing significant benefit in terms of survival, then you would know that it really does work. Okay, fixed sample design versus group sequential design. Fixed sample design is sort of the grandfather of trial design. Back in the days, they all used that. And that means that once we have a project and we have a trial and we establish how long we're gonna run this trial, say like 10 months, 12, whatever, we're sticking to it. From the beginning to the end, we're running through the entirety of the trial and sticking to that timeline. However, as people start running trials, they realize that there are some treatments that simply are just bad. The patients are really experiencing bad adverse effect or just doesn't work, and we would like to stop the trial, or vice versa. The treatment shows it's really promising. Can we stop it so the other arm can receive that treatment? So people start moving towards group sequential designs, which is this trial that allows the implementation of this thing called interim analysis, meaning that you can run these survival analysis at designated time point of your trial to see based on the data that we gathered so far, do we want to stop it? Do we have enough evidence? Or do we want to adjust or modify anything down the line? Say like we expected mortality rate to be this, but then in reality, it's a lot lower than we expected. Are we gonna have enough evidence or statistical power to reach any meaningful conclusion? Do we need to enroll more people? Sort of that, it facilitates that decision. So you would say, okay, that obviously sounds like a lot better than fixed sample. The caveat then is that whenever you run any analysis, there is always a significance level that you set, right? Like alpha level of usually 0.05. And that really means that if you observe a significance difference between two groups, there is a 5% of chance that this difference is due to chance, due to randomness. It's not really a real association. So whenever you run a interim analysis, say like at time point A, and then you observe a significant difference or whatever, but then you wanted to modify the trial in some ways based on the result that you're getting, and then you continue running the trial, and at time point 2 run another interim analysis and to see what's going on. The time point 2, that the significance level you set at time point 2, again 0.05, really isn't, if you observe any significance level, that is not 5% of chance still, because you modify the upstream interim analysis, or you modified the upstream study, and you already conducted an interim analysis. That means that there is an additive effect of the significance level at the second time point, because you have to take that into account. So it inflate the alpha value, meaning that you have a higher there, even if there's a significance level, there's a higher chance of it being due to chance than actually a significance. So some really smart people devised some really interesting spending function, alpha spending function to sort of dissipate that effect. And we don't have to worry about that. But I just want to mention that that's like the caveat that you should be aware of when you look at the trial and see if they sort of like implement a spending function to ameliorate or alleviate that effect. Okay, time to event analysis. Back to the topic that we usually know. Time to event analysis, the most used analysis is obviously the Kaplan-Meyer function. And if you haven't seen it before, you will see it today. It's plotting the remainder of patients in a group on y-axis over x-axis, which is the time point. So it usually looks like downstairs. It usually looks like stairs that's going down. And if you see a difference between two groups, then you will use log rank test to see if that significance is different. That difference is significant, i.e. not due to chance. And then you will run Cox proportional hazard model to give you hazard ratio and other parameters, progression-free survival. Hazard ratio is an interesting concept. So ratio denotes that you're comparing one thing over the other. And in this case, the thing that you're comparing is the hazard rate. The hazard rate really is essentially the slope of your survival function. So if today you plot a survival function that looks like this, like the Kaplan-Meyer survival, there will be a line where you can fit through the data point that usually has a negative slope of as time goes on, there's less patient remaining. And the hazard rate is the slope of that line. So you're comparing directly the hazard rate of one group versus the other. Usually the group on the top is the treatment group. In this case, it would be the combination group, and the group on the bottom is the comparison group. So a hazard ratio of 1 denotes that there's no difference in risk of experiencing death between two groups. We like to see, at least in this trial, a hazard ratio of less than 1. That means the patient on top is experiencing less death compared to the patient on the bottom. That tells you whether two drugs or two arms has difference in terms of outcome, but it doesn't tell you sort of the magnitude and how long it takes for the patient to experience those outcomes, and that the progression-free survival then supplements that. Okay, that's it. So for demographic variable, for demographics that they look like, I specifically highlight the ones I thought is significant. So in this patient population, there are a lot more males than females. And the etiologies are almost exclusively all from hepatitis B, because oh, sorry, I didn't mention that earlier, but this trial was conducted in China. So hepatitis B is obviously a lot more prevalent there than here. And this patient population is also super sick. Look at their AFP variable. Almost half of them have an AFP value of more than 400 when clinically above 40 is considered elevated. More evidence that they're really sick. So more than 75% of them on average has multiple intrahepatic tumors that are more than 5 centimeters, pretty large. And also around 70% of them already have macroscopic portovenous invasion, as well as more than 50% of them, half of them, has extrahepatic spread, which further justify why we're doing this study, since lenvatinib is a systemic treatment. Okay, so what tests do they use to look at their outcome? And we already covered a lot of that, because that's the good news. In the beginning, they use a log-rank method to try to estimate how many patients they would need to enroll in order to reach a statistical power that will draw a significant conclusion. And that a lot of variables goes into that, including the estimated median overall survival of the treatment and how long the trial is going to last and what's the expected dropout rate, things like that. The spending function that I talked about earlier that is used to curtail the type 1 error of false positivity they use is O'Brien-Fleming. Then really don't worry about that. Okay, the next one, they use Kaplan-Meyer to plot the progression survival, and use Cox proportional hazard model to calculate their hazard ratio. And last but not least, they also look at stratify hazard ratio of each group. Basically, this is to see in complex patients like this, there will be a lot of confounding variables that can be independently linked to survival outcomes, and you want to make sure you control that in order to give your results a generalizable or validation of your results. And they're being really conservative here, which I'm really surprised that the p-value they use is 0.1, and usually researchers choose 0.05 for inclusion, meaning that if it has to be more than 95% of the more than 95% chance that this variable is linked to this outcome, will I include it as one of the confounding variables or inclusion variables for analysis, but they chose 0.1. Okay, so finally, what everyone was waiting for, primary efficacy outcome results. For the combination group, 26 people were downstage to surgery, and 2 actually experienced complete response per RECIST criteria, versus monotherapy, only 3 patients downstage, and if you remember earlier, they are comparable in size, half and half of patients. So this is really a fascinating result. And this response or efficacy holds true regardless of which RECIST criteria you use. And quick recap, and RECIST only look at viable tumor and not the whole nuke area after the treatment. And then for each of the criteria, TACE group, the combination group, shows a higher or significant rate of experiencing any response compared to just the monotherapy. Okay, so Kaplan-Meier curve. The top one, A, is the hazard ratio of experiencing death in this case, and the bottom one is the progression-free survival. How many months do average patient experience before they experience the event? And you can see that in both of them, these criteria or the outcome measurement, the combination group shows superiority over just the monotherapy. The TACE group has a median survival of 7.8 months versus the monotherapy only 11.5. And this holds true after they included all the potential variables that can confound the results and run analysis. Still holds true of p-value less than 0.001, meaning that there's less than 0.1% of chance that this difference is due to chance. Okay, so this is as I said before, they look at almost all the potential confounding variables and stratify them categorically. So of course, if you're older, then there's more chance for you to sort of die in this study than if you're younger. So they stratified them based on groups and then only compare the stratified group between 2 arms and see whether the outcome result still holds true. And if you can recall earlier, we said HR or hazard ratio, when it's less than 1, usually that means the treatment group, which is true in this case, is doing better than the comparison group. And at the bottom, you see on the left side of less than 1, it favors TACE, and on the right side, it favors the monotherapy group. And almost all stratification, after even they're stratified, the outcome still holds true for those subcategory. One thing to mention is that if you see the line crossing, this forest plot line crossing over to favors Len, and that means the 95% confidence ratio include 1, and that result is not significant, meaning that you cannot draw any conclusion, even if the hazard ratio, for example, for primary tumor of no appears to be 0.3, meaning you would think that, wow, the treatment group is doing so much better, but in fact, the confidence interval include 1. That means that this, even it's 0.3, it's not significant. And upon further, if you investigate it, you will see that there are only 2 people in the TACE group for that. And that might be the reason why it's not significant. There's just simply not enough statistical power to draw that conclusion. Okay, in the supplement analysis that was not included in the main paper, they look at individual variables and whether they are significantly corresponding to the outcome of mortality. And they found that both the portal vein thrombosis and treatment allocation were independent risk factor of death in this study. And the treatment allocation in this case will be whether you were randomly placed into combination group or monotherapy group, which we show that, yes, that makes a difference. And then second is portal vein thrombosis, which usually denotes a poor outcome. So that's expected. Okay, so we have established that it worked, but what is the side effect? And is it so bad that maybe we don't want to use it, even though it shows better better efficacy? And the result is that all the significant side effects that's associated with the combination group are all post-embolization syndrome, including abdominal pain, nausea, fever, and vomiting, which you will see after TACE anyways. So, and at the bottom, you see increasing liver enzymes and hyperbilirubinemia, which also indicates liver dysfunction, which is also expected really, because you're directly doing intervention in the liver. Okay, so finally, we've reached the end of this trial, and this is their consort diagram really showing you the flow of patients through this trial. And again, on the left side is the TACE group, on the right side is the monotherapy group. The left side, you can see again, surgical resection, 26 patients achieved that versus only 3 on the right side. And given that the size is comparable, it's really fascinating. Okay, so of course, with all studies have limitation. In the one that are glaring at us in the study include that the etiology, it's not generalizable, at least to the Western audience where most of the HCC cirrhosis comes from NASH or HP or hepatitis C. Also, they use an open label design again, where everybody knows what treatment you're getting, but really there's not really a way around it in this case. Okay. The takeaway then is that compared to monotherapy of lenvatinib, the combination therapy of lenvatinib and TACE exhibit greater and more significant outcome survival, and with similar safety profile or expected ones in patients diagnosed with primary advanced hepatocellular carcinoma with this specific etiology. Remember that most of our patients' cirrhosis came from Hep B infection. Okay, so now that we've get that with all solutions or results comes with more questions. Now we want to know, is this result generalizable for patient with HCC with other etiology in other population? And what is the dose response relationship for lenvatinib? And then is lenvatinib comparable in its effect with other multi-kinase inhibitor like sorafenib or other monoclonal antibodies like anti-PD-1 or anti-PD-L1 maps with this patient population of advanced primary HCC? And last but not least, we were sort of surprised to see that there's not any consideration of quality of life after they receive treatment. We thought that in the future study, we should include at least a measurement of how well these patients are doing after they receive the treatment in the group, because gaining 3 more months of life really doesn't mean anything if you are not spending it with your family in the end. So anyways, so that's the end. We're now open the floor for discussion and questions.
Yeah, that was a great discussion. And again, the stats are always a little bit over my head. I think a few of the people in our room, we have a bunch of students and residents and some faculty in here, we'd all agree, but excellent job presenting it. Let's just kind of, if hopefully there's some questions in the audience that we can answer, but kind of go over kind of my approach to hepatocellular carcinoma. We saw a few patients today in the clinic, a couple of new consultations, and kind of go over the approach, and then hopefully have some questions answered. So any questions, Tulasi or anyone? Jonas, there's a bunch of people here. I don't know, Subhash is still here. Feel free to ask some questions that we can answer. Amir.
Thank you, guys.
Go ahead.
Yeah, sorry. That was a great presentation, guys. I just wanted to add, if anybody wants to DM me, just if they want to be anonymous, no worries, you can do that, and I can read your question out loud. And I can also read out questions from the chat if you want to just type it.
I guess one
Okay.
question I had is, hi everyone, I'm Camden. I'm
Hey.
an M4. I just was curious, like, kind of, what are your guys' thoughts for the translatability of this kind of similar approaches to other systemic immunotherapies and other, Y90 instead of TACE, kind of other interventional approaches, and kind of, just would love to hear your thoughts on that.
Yeah, so this study used DEB TACE and conventional TACE, but you're right, we don't know Y90. There's not a lot of great comparative data comparing Y90 to TACE. We have some data looking at DEB TACE versus bland embolization. Karen Brown, we just talked about it earlier, where in her single center RCT didn't really show a benefit. There is some premier data, which is single center phase 2 trial. There's other data like the TRACE, which showed some progression-free survival, but not powered or studied in a fashion that would tell us I don't know what the Rowan trial is. Maybe Subash can enlighten us. But the TRACE trial didn't show, we didn't look at OS, so that's really what it comes down to. And then there's explant data where Ed Kim looked in the Mount Sinai, looked at ablative dosing Y90 in patients who are kind of questionable ablative candidates and showed pretty good explant data of necrosis. So we have data, but not level 1 RCT multi-center looking at specific endpoint of overall survival, comparing those two options. But there are more and more trials ongoing looking at yttrium 90 as well in combo therapy. I think someone asked a really good question as well. Does anyone know how frequent lenvatinib is used in practice compared to other immunotherapies like durva, right? So what Dr. Goody is discussing is basically, if you look at first-line therapies, it started off in 2008 with sorafenib, which is sharp, and then Asia Pacific proved that it also worked in the Asian cohort. But you only got about 2 months of increased survival. So I put a lot of patients on sorafenib. I don't know, Dr. Katsagra, you probably saw a lot of these patients as well. And they didn't feel so hot. We gave them a little bit of time, but they're like, I'd rather not be on this and live less, right? So quality of life is very important to patients. They want to do what they want to live life, not nauseous, not anorexic, not feeling miserable, and get a couple of weeks and being bedridden. So anytime you can keep them out of the hospital, anytime that you can keep them not ill is ideal, okay? So these are all things that when you talk to a patient, the family, you need to counsel them on. That's why quality of life is very important. Now, if you look at Subhash's question, if you look at sorafenib, and then Dr. Billa, who's one of my integrators, he taught me about Reflect when he was a MS4 back in the day, 5 years ago, and that showed that lenvatinib, which is another TK inhibitor, had good overall survival data when compared to sorafenib, so it got first-line indication. But then more recently, as Subhash was talking about, is the IMbrave 150 trial. Now you're using immune system, not a TK inhibitor, but your own body's T cells are getting revved up to kill the tumor, right? So you're activating your immune system using, there's 3 kind of agents now used, PDL1, PD, and programmed death ligand 1, and CTLA-4 inhibition. By inhibiting these receptors, you're now activating T cells. And what's maybe in the future will be what's called CAR T cell, which is chimera. You take the cell out, you activate it with the antigen and the T cells, you propagate it, and then you put them back in the body so it can attack the tumor. So your immune system's revved up. Now, the problem is if you look at the IMbrave 150, mostly child's A, but also you could not have varices, meaning if you had portal hypertension, risk of bleeding, the Avastin is relatively contraindicated. But then that's where durvalumab or doublet therapy, now you're taking CTLA-4, 2 immune activators, and it showed a benefit when compared to kind of standard systemic agents like sorafenib. So now you've got 2 immune therapies that are better in overall survival than sorafenib. So now you have a couple of other first-line treatments that are now available to our patient population, which is a little bit less toxicity, better tolerated, and with good reduction in tumor burden, all right? So, and we're increasing survival. So now we're giving quality and quantity of life and these adjuncts. What we don't know is like, where do those agents and Y90 or TACE or ablation, where do they play hand in hand? And so this is where we need more clinical trial data to know exactly where to do it. So it's still a bit of an art until we get more data. Hopefully that answers that kind of complex question. And I'm not sure about the Rowan trial. Does anyone know the Rowan?
It looks at Y90 in addition to STRIDE.
Oh, STRIDE. So it's the durvalumab with the tilemab. So one-time dose of Temra to activate, and then the durva throughout, and then Y90. That would be an interesting trial. So we'll see what that shows, you know? Wow. Yeah. So yeah, there's some incorrect. Thank you. Cameron. Yes, go ahead.
They when they say TACE in this study, they include both emotion and drug-eluted beats approach, and it did run a comparison study to see whether there's outcome difference between patient who receive one versus the other, and there is not. Just want to add that.
Yeah, I mean, the challenge is when you're doing subgroup analysis, it's hard to know, right? So you muddy the water a little bit, right? So the question is, did DEP TACE have a benefit compared to conventional TACE? And the honest answer is we don't really know, right? So the Precision 5 was a randomized controlled trial by Johannes Lammer from Europe, and he looked at 6-month outcomes, but he looked at adverse events. Very high dose of adriamycin, just 300 milligrams, and the main toxicity he was looking for was hair loss, you know? So there were higher hair loss, and there's some suggestion that it may be better at DEP TACE, but it's never been proven. So, you know, I asked him why not an overall survival. It's really to get CE mark, which is the European equivalence of approval for DEP TACE. That's the only reason that the company did it. So you have to recognize when the companies push these clinical or these devices or companies, they may not have an interest in running a trial because they already have it in activation, you know?
So they're just doing safety, efficacy, not superiority.
Correct, like phase 1 and 2 at most, right? And you're not looking at like, is this going to change this? Because whenever you're doing a trial, you should look at 3 things. Is it safe? Is it effective? Is it durable? And you've got to compare it to historical gold standard. And I think Subhash is right in the sense that we could argue that the gold standard, and what we don't know is, should it be INBRAVE 150, which is atezolizumab and bevacizumab, or should it be the doublet, which is durvalumab and tremi, which is a Himalaya 3? So again, these are subtleties, but important when you're counseling a patient, right? I do think I have some patients who are intolerant of the other drugs and have been on Lenvimo. And for those patients, I do think that this is something I will bring as an adjunct personally. I don't know. What do you think, Karthik or Zaim or Austin?
Yeah, I think so. I think if they're not, because some people just aren't a candidate, right, for
Atezolizumab, yeah,
right, for whatever reason. And if they are going to be considered for other alternative first-line therapies, I think this is pretty
pretty compelling, right?
Especially within the Hep B population.
Yeah, for sure. I have a Hep B patient that I think just makes a lot of sense to do, right?
We see them not infrequently.
Right, correct.
I wouldn't say it's the majority of my practice,
right,
but we get a decent share.
Yeah, and so I think it is at least something that I can add to my repertoire. But you know, so the things that I think about important, if you can go to BCLC real quick, Spencer or Eleanor. When I look at hepatocellular carcinoma, it's a growing incidence. It's probably about 30,000 new cases going around, right? Most of it's going to be at transplant centers, right? Or you know, we have like 5 or 6 transplant hepatologists, so we're going to see a lot of this, right? You know, it's very important to understand kind of the etiology. And so what are the causes, anybody, of HCC, like the cirrhosis and HCC? What are the different things?
Metabolic associated.
Yeah, so metabolic associated is very common. What else? Alcohol, ASH, right? So mild metabolic associated liver disease and ASH, or alcohol associated liver disease.
HCV, HBV.
Yeah, so viral, HBV without cirrhosis, right? Because the virus is causing it. HCV leads to cirrhosis, so they almost always have cirrhosis.
Deposition diseases. So
yeah, iron, copper deposition, right? Good.
Alpha-1.
Autoimmune,
alpha-1 antitrypsin, exactly. Yeah, exactly. So these are the kind of things that you're going to see pretty frequently. So you should know when you're seeing a patient with cirrhosis, what the cause is. So you send off these hep serologies, the ANA smooth muscle antibody, the iron and the iron studies, and the ceruloplasmin, et cetera, right? So you do that workup first, right? And then are they diabetic, or are they obese, or the MELD? Is there what's going on, right? If you have a patient that you're worried, right, they have fatty liver or risk factors, then just you can do a FIB-4 score, right? So you do the FIB-4 calculator, and you can assess based on a certain number. Should that is basically looking at transaminases. So if the ALT or AST liver enzymes are elevated, that's such as some hepatocyte injury, right? So that FIB-4 score can guide you to, should you get liver elastography to look at true fibrosis, right? Or what you should do. So again, these are things that you're going to see a lot of liver patients you should understand, right? Remember, heart, lung, liver, kidney, brain, right? Anyone who's rotated viscera should know heart, lung, liver, kidney, brain, cold, right? So in the liver standpoint, what 3 labs tell me how well the hepatocyte is working? INR, T-Billy, albumin, right? Yeah, so T-Billy, INR, and albumin tell me the hepatocyte is working well, right? Because the liver it makes protein. It makes the vitamin K dependent factors. A lot of the clotting factors, the majority of them are made by the liver. And albumin is a very important transport protein, is made in the liver, right? So liver is very important, right? And then what is the other kind of worry that I have? What other worry do I have in cirrhotics besides hepatocyte synthetic function? Portal hypertension. So what single lab can I look at to tell if this patient has portal hypertension or not? Platelet count, right? So less than 150, you start to worry. Less than 100 is probably the real deal, right? They have big spleen, they sequester. Even though thrombopoietin is a hormone made in the liver, that's not the primary effect. The primary effect is splenic sequestration. So if I look at those 4 labs, T, billy, INR, albumin, and platelets, I already know the stratification of this patient almost always, right? Now, what is he? So that's the liver. The tumor, it says here, right? This is a Milan criteria, right? Essentially. So 1 less than 3, 1 less than 5, 3 less than 3 is kind of early to kind of a stage tumor, and that's transplantable. And that was based on Mazzafaro from Italy. He took these patients and said, I'm going to cut out patients with, because they did this. They accidentally took out livers and cirrhotics, and so the explant had hepatocellular carcinoma. And wow, these patients still live the same as if they didn't have hepatocellular carcinoma, right? So like, oh, well, let's take the subset, right? Mazzafaro did this in Milan, in Italy. Let's take a subset and cut out these patients with 5 centimeters, 1 less than 5 or 3 less than 3 centimeters, i.e. Milan criteria, and see how they do. Then 4 years, 75% survival, right? And then Yao in UCSF, he did a study where he said, maybe we can go even further because we're taking out these explants, and what you see in pictures is not really what's on the explant. Let's go to 6.5, a total tumor diameter of 8. Again, very good survival for 5 years, right? What is the likelihood of recurrence if you get a transplant of HCC developing?
Really low, like 5.
Yeah, less than 10% in 10 years. What is the likelihood of recurrence of HCC if I cut out the tumor or burn the tumor? Curative intent in a cirrhotic.
70%.
70% at 5 years. So you don't get rid of the tumor recurrence rate even with cutting it. Now, what trial was done that's an adjuvant therapy to resection and showed benefit?
That was in Brave 050.
In Brave 050, right? So now we're getting to the neoadjuvant, the adjuvant, and combo therapies, systemic agents with what we do. So it's very important that you understand these core concepts when you're dealing with hepatocellular carcinoma. So we know the hepatocyte function, we know portal hypertension. What are the sequelae of portal hypertension that you're going to see? Anybody? What are the side effects of portal hypertension?
Hepatic encephalopathy.
Yeah, hepatic encephalopathy.
Esophageal varices.
Yeah, varicose bleeds. And one more. Ascites, right? Portal hypertension, you can't reabsorb the thing. Is it high sag or low sag? Yeah, good, ascites. High sag or low sag, and what does that mean? So anybody? High sag, right. And what does that mean to you?
So high sag means you subtract the serum and the ascites, and greater than 1.1 would be high sag ascites.
Right, and why is that?
So there's something, it's like the albumin's not leaking out.
Yeah, it's transudative, right? Yeah. It's the and so why is the protein high in heart failure, high sag ascites? Because it could be right-sided heart failure causing congestive hepatopathy, but not in cirrhosis. The fibrosis. So in heart failure, you don't have the tightening of the junctions as much. So you allow the protein to seep out. So you have total protein by 2.5. So anyway, as you start to understand this, majority of ascites are going to be portal hypertension related. If it's low sag ascites, what's your differential possibilities?
We looked it up. So pancreatitis.
Well, what's the commonest things that you're going to see low sag ascites for? Yeah, pancreatitis. Cancer.
Yeah.
And TB are your top 2 differentials, right? Mm-hmm. Cancer and TB. Sometimes you do a peritoneal biopsy, right? So you should understand because you're going to see a lot of ascites. If you're doing a para, the easy part is poking the needle. But do you understand?
I'm touching to go with that today. It was low seg.
It was?
Well, presumably we didn't draw serum alpha. See?
Oh, you got to do it within 4 hours. You got to draw the serum albumin within 4 hours.
It's pretty high. It's like 2.3.
What? The ascites?
Yeah.
Oh. But you should technically still do it 4
Yeah.
hours. Anyway, so we're just talking about a patient. The easy part is a para, but is it high sag or low sag? Because if it's high sag ascites, how do you treat it?
So Lasix spironolactone,
Right, but
sodium restriction.
2,000 milligrams of sodium,
Yeah.
and then Lasix and spironolactone. What's your dosing for the Lasix spironolactone?
50 to 20.
50 of what?
Lasix.
50 milligrams of
Spironolactone.
spironolactone and?
The 20 of Lasix.
Right, 20 milligrams of Lasix, right? You case sodium creatinine in 2-3 days or within a week, right? You can titrate up to how high?
480
400 milligrams of
spironolactone.
Yep,
eight
and
is of
higher,
Lasix.
right? 50-20, what's the ratio?
Oh, right.
160. You're
160.
160.
Yeah, so as long as the K, creatinine, and sodium are okay, right? You can do that. So be cognizant of that, right? So that's like refractory ascites, right? Some people are diuretic resistant, but be understanding of these concepts, right? So again, when you're dealing with liver cancer, the easy part is putting a catheter and doing an embo. The hard part is managing this disease. That includes ascites management, varices management, putting them on. If they have varices and they've been banded, what medication should they theoretically be on and why?
Correct.
Good. Correg is carvedilol. What else?
Propranolol.
Yeah, non-selective beta blocker or carvedilol, right? Alpha, so propranolol or nadolol, right? The goal is to reduce portal hypertension, reduce flanking circulation, and you can even check that with what procedure or study can you do to assess the effect of that beta blocker. Anybody?
Measure pressures. Like
Yeah.
Transhepatic pressure.
Right, doing a hepatic venous pressure gradient with an occlusion balloon, right? Exactly. So you can check, is your beta blocker working or not by seeing, is there a gradient difference when you do a transhepatic where you go through the neck, through the hepatic vein, put a balloon up and see is there a gradient or not that's reduced. Because that balloon is like a pulmonary capillary wedge. We're looking at a left atrial estimate. We're looking at a portal estimate. So again, these are important constructs to understand. So we talked about ascites, we talked about varices, we talked about beta blockade, we talked about the hepatocyte function, we talked about high sag ascites, and we talked about hepatocytic carcinoma. The diagnosis is an imaging diagnosis based on MR or CAT scan, right? And it's called LIRADS or OPTN. It's a bright early and dark late compared to the normal liver. And that is the tumor, HCC by definition, and a cirrhotic or Hep B. You don't need a biopsy because it'll bleed. And the few deaths that I've seen over my career, until recently, has been from hepatocytic carcinoma biopsies. It's most of the ones I've seen until recently have been that, right? Saw cholangiocarcinoma recently, but most of the ones have been that, okay? So be cognizant of that. There is a risk of bleeding. If you bleed and you seed, Lovett published 12% as low as 1% with coaxial. That can impact their chance or candidacy for transplant, okay? Interventional oncology and ablation is equivalent to surgical resection for certain tumor types. So these are both curative intent treatments. That's important, right? Anything I'm missing, Dr. Katsager?
No, it's an amazing review. I think I'm ready to take care of HCC.
Dude, you've been taking care of it since you were PGY1, dude, or MS4.
No, but dude, we have to have this down, right?
100%.
Very few things we're so heavily involved with.
Dude, you can save so
As
many
a
lives,
specialist,
right?
You have to have down.
100%. All right, those are my main things. Any other pearls?
I think I was on that, but he's extrahepatic disease.
Any other thoughts, questions? Eleanor, Spencer, Tulsi, anybody?
Great discussion. I was just wondering, have the results of launch resulted in any changes in like regulatory approval or treatment guidelines?
No, I mean, that's a great question. Well, it should. I think, I didn't know about it until Camden pointed it out to me during the rotation. But now that it's in my repertoire, I will start to utilize, I've definitely utilized this data. But part of it is just education, right? So now you go to your programs and go, hey, what do you guys think about launch? And eventually it'll come into play, right? So the exciting thing about Transnational is it may change your own approach to treatment. Go bring it up. Like, hey, this patient with Lenvatinib Hep B, why don't we do combo therapy? We can increase OS, or we can downstage a resection. So I think part of it is it takes 17 years to get human or physicians to change their practice, this is another way to do it by doing these trials. But I think the quality of evidence is there, and I certainly will change my practice and have already accordingly. I don't know, Kaiser? Yeah, 100%. The data is very compelling to me. You're changing OS, you're improving your resectability by 8-fold. It's not a joke. In an advanced population, extrahepatic spread, vascular invasion, APs that are pretty high, all bad surrogates. You got bad biology and a combo therapy with a TK inhibitor, and what we do is pretty impressive to me. Anyway, that's my thoughts.
Yeah, I was wondering, what does it take for the insurance company to sort of, what level of evidence does it take for them to pay for these new treatments?
I mean, that's a good question. A lot of it's going to be based on the insurance company and the pre-authorization, et cetera. And you have to kind of fight for your patients, right? So you have to be the one sending them the emails, sending them the literature, and then pushing hard as an organization or society to change that practice. And then it goes into NCCN guidelines, things like that. That makes it more of a plan. So I think that would be the next step is like, hey, let's shift this in the NCCN guidelines and talk to cancer societies about it. But it's good quality evidence. Any other thoughts or questions? All right, well, I appreciate everyone's time. Thanks, Eleanor. Thanks, Spencer. Thanks, Lucy. Thanks, everyone, for joining, and hope you learned a little bit about liver.
Super exciting. Thank you everyone for being here. See you at the next one.